Welcome everyone to our next 3D Echo session. This is going to be about providing person-centered care and integration of family and caregivers. We have Dr. Ali Brock to present to us today, and I will let her take it away. Oh, before we do that, let's just do a quick little round of introductions for folks. So my name's Amber Rogers with Mountain Pacific Quality Health. And Dr. Brock, do you want to introduce yourself?
Sure. My name is Ali Brock. I am a physician at Riverstone Health in Billings, Montana. Board certified in family medicine and geriatric medicine.
Awesome. And I'm just going to pick on a couple of people that have been some of our regulars. We won't go through everybody. Kim Wolf. You want to put your cameras on and say hi?
Yeah, hold on 1 minute here. Are we just introducing ourselves?
Yep. And what organization you're from?
Okay, did that turn on? Yeah, it did.
Yep.
Hi, I'm Kim Wolf. I'm a new PMHMP and I'm out of Daniels Memorial in Scobie.
Oh, nice. How about Rihanna Curtis? And if Rihanna's not there, how about Melissa Bates? You guys are shy. Okay, well, nobody wants to talk today. Maggie and Mark, do you want to say hi real quick?
Hi, I'm Mark Marvella. I'm with Mountain Pacific.
Awesome, thank you. Oh, my AV is not working, of course. Okay, let's go ahead and Debbie, I don't know how to pronounce your name.
Hi, I'm Debbie Shimiz. I'm with the Executive Office on Aging in Hawaii.
Oh, perfect. Great to have you. Feel free to chat in any of your wisdom there. Okay, next slide. Did want to let you guys know that we do offer nursing continuing education credits for this. You do need to fill out the evaluation form if you are going to want those credits, and we will provide those at the very end of the entire series. Next. I do have a conflict as well as Reza for some stocks. All of those risks have been mitigated. Next. And that's it for announcements for me. So anybody else have anything?
I do not have any disclosures to clarify that as well.
Yeah. Perfect. Okay, why don't you take it away?
Sure. So like I said, I work at Riverstone Health down in Billings, and just to give you guys some context if you're not familiar, so it's a federally qualified health center. I really enjoy taking care of elders with cognitive impairment. I practice in several settings, including the outpatient clinic setting, both family medicine, though right now I have a pretty heavily geriatric panel. I also see patients on the inpatient side at both Billings Clinic and St. Vincent's Hospital, and I run our nursing home program, so see patients in various skilled nursing facilities around town. So in my training, I've had the opportunity to see persons with dementia be cared for in many different care settings and across different systems. Patient and person-centered care is one of my favorite things to talk about, and I think most of us who do work with folks who are either elderly or have cognitive impairment are intuitively very excited and very good at this. So hopefully you'll walk away with some concrete tips about how to make sure the care you're providing is person-centered. So that's our topic for today. Learning objectives. So hopefully at the end of our meeting today, you'll have a better sense of how to determine the values and preferences of patients and caregivers, as well as family members, really to guide all aspects of their healthcare needs and to support their goals. Recognize indicators for quality patient-centered care, as well as recognizing that the individual with dementia is on a journey, and that journey looks different for everyone. I sometimes think about dementia care when I'm counseling families like post-stroke care, in that it can be highly variable what the clinical course looks like and the time frame. And so the families are often seeking anticipatory guidance, and they're often looking to us to do that. The American Geriatric Society in 2015 made the following statement. So, definition of patient-centered care, that individuals' values and preferences are elicited and once expressed guide all aspects of their health care, supporting their realistic health and life goals. Person-centered care is achieved through a dynamic relationship, not just with the patient, but with all folks who are important to them, which can be family, friends, healthcare providers, and that really guides and determines what their care looks like. This is one of those slides and one of those statements that I think most of us who work with elders will look at and say, yes, of course. I can also say on the inpatient side and taking care of complex elders in a federally qualified health center that we sometimes lose sight of what matters to the patient, right? I think of geriatric medicine as medicine on steroids. There's a lot of complexity, and sometimes we will get stuck in the weeds in trying to navigate the system and kind of forget to step back and ask the patient and the family what's important to them. So on that note, instead of solely managing disease, people want to live and function as well as possible. And I would say that that is absolutely universal for all of us, right? Not just individuals with dementia. And we want to place emphasis on autonomy, personal choice and goals, likes and dislikes, beliefs, values, and abilities, both past and present. And often to get that picture of likes and dislikes, beliefs and values, we're not just talking with the patient, we're talking with their entire care team. Indicators for quality person-centered care. Think of as being able to live life at the highest functional level possible with the least amount of intervention. As a nursing home provider, I also think about that as the less restrictive or least restrictive learning or least restrictive living environment, right? So just this morning saw a patient at a skilled nursing facility who's wanting to step down to assisted living, right? Constantly reevaluating, understanding what's important to folks and what they're capable of to keep them as independent as possible for as long as possible. Another indicator for quality person-centered care is making sure that we have capable and available services in the community to make sure that we're able to meet the needs of elders. I'm not sure where all of you are based on the call. Billings for me is a much smaller setting than where I trained. My geriatrics fellowship was in Minneapolis, and so it's been quite different coming here and understanding that Billings is actually quite heavily resourced compared to other areas of the state, but that there are still some large gaps in services. But making sure you're familiar with what's available to help optimize care for your patient. And then making sure that the patient and their caregivers feel confident in how to navigate the healthcare system. Obviously, we think of the patient as the center of everything that we do, right? Folks who have cognitive impairment may have language issues early on or have difficulty with communication later on. It can be highly variable. And so the extent to which the patient themselves is able to express what's important to them can vary, which is why it's incredibly important to know who their support system is. And that's often the language that I'll use. I also like VIPs, very important people, right? Knowing who this patient considers as family, whether they're true family or chosen family. So we think about family members, often kids, or friends, sometimes neighbors, can be really integral to the care of patients with cognitive impairment. And I think about that not just in their role in providing care for the patient, but also in their role for being able to share concerns or collateral history that we may not be able to elicit from the patient themselves. There are a lot of different roles that a cognitively impaired patient's support system can play. So this is an example of a few. So when available and desired, family members or friends or other VIPs are a member of the support system. Can play a variety of roles. So as I mentioned, they often are really critical informants or historians, especially when you are just assessing cognitive impairment and trying to parse out maybe the etiology or the severity of the impairment. In the early stages of dementia, they can be excellent care partners to help maximize independence. I think we're all familiar with patients who have full-time caregivers, right? Whether that's a spouse or a child or otherwise. And we can also have VIPs that are legally documented as healthcare proxies or power of attorneys. Again, with the goal, working with all of these individuals in the support system to help individuals with Alzheimer's, but really all elders and elders with cognitive impairment live as independently as possible. Anytime we talk about a care team and a support team for a patient, HIPAA comes up, right? We want to make sure that we have the permission of the patient when they're able to give it to include certain individuals in their healthcare team. So there are some examples listed here. Certainly we want to make sure that the patient's able to tell the provider if it's okay to talk with certain individuals. There are situations where a patient may be ill and in the hospital and unable to give that consent. And the bullet point that says using professional judgment, we can share information as one that comes up often in that situation. Generally as providers, we step back and try to assume what's best, what's in the best interest of the patient to help better understand their goals and their desires, if that's not explicitly documented already in an advance directive. This is one of my favorite slides, especially for learners, right? So we have a residency program here, so I'm on faculty there. I work with a lot of residents as well as medical students. And I really stress to them that, just like we don't say homeless people, right? We say people experiencing homelessness. We do person-centered, patient-first language. Persons experiencing dementia or living with dementia, the person is at the center of everything that we do, right? So I have very often witnessed encounters where you might walk in and you have a family member who's used to speaking for that patient or that individual who maybe just instinctively answers all the questions, or the elder's so used to them talking or being talked over that they'll just look to them to answer. So that first bullet point of talking to me directly, the person with dementia, I think is one of the most critical. I will often, not often, always, anytime I'm entering the room, especially if there's individuals there that I haven't met before, make sure that everyone's aware who's related to who and how, right? Generally, if they're a supportive person. Sometimes the person with cognitive impairment can tell you who's with them. But it's really important for me to get my bearings. And again, in a very busy clinic or hospital setting, I think we sometimes get in and just start talking without understanding who's there with the patient. And this is their support team. So that's a very critical first step. Tips, always telling the truth. It can be really difficult, particularly with dementia diagnoses. I remember one of the most formative discussions that I had in my geriatric fellowship and working with a geriatric psychiatrist in a memory evaluation clinic is that when you're giving a patient a diagnosis of dementia, the family is hanging on your every word, right? This is a life-changing diagnosis. And so it's incredibly important that you be prepared for the conversation, that you anticipate what questions might be asked, and that you have information available about services or next steps. And certainly the time as well. I would say most patients with dementia I see at least every 3 months. I have many that I will see monthly or sometimes every week to 2 weeks in the clinic setting, right? And oftentimes the patient themselves is medically stable, and the appointments are more to make sure that the family is feeling supported and that we're able to give that anticipatory guidance depending on what's going on in their lives and the rate of their cognitive decline. Brief intro. Does anyone have any questions?
Feel free to put any questions in chat as well.
I think the other thing that I would just mention in general, when I think about communicating with care teams and making sure that the patient's at the center of what we do, I see this a lot in the skilled nursing setting, but it's really important to have consistent and clear communication with families about how a patient is doing. When I think about situations, we might say a difficult patient or difficult family, when really it's a patient or a family in difficulty. There is rarely a situation where being clear and consistent and transparent in communication hasn't helped that, right? Different patients and different families have different expectations and what they need, whether that's in the skilled nursing setting or elsewhere. And I find it really helpful when making a new diagnosis or when taking on a new patient in the skilled nursing setting to kind of have that discussion about what communication they need, how often they want to be updated, making sure that I'm understanding their expectations of me as a member of the care team and vice versa. And laying that out ahead of time can make it a lot easier when things change or if there's a decline. Oh, Amber, you're muted.
Should figure that out by now. I was just wanting to ask the group, for those that have had experience in delivering these types of diagnoses, what's something that works really well? What are some of the scripts that perhaps you've worked on delivering, and or if there's conversely something that you wish you would have done better? We can all learn some lessons from those as well. Any comments from the group? Dr. Brock, do you have any particular way that you start to have that conversation to include folks?
Yeah, it definitely depends on the care setting. I think in the outpatient setting, it's usually been at least a month or a few weeks of assessment. And so I feel like when we get to a visit where we're kind of synthesizing information and giving a diagnosis, usually the family and the patient or their support system are prepared coming in to know that that's what we're going to be talking about. I think it's incredibly important to use the term dementia, right? We can say memory issues, we can say cognitive impairment. There's a lot of words that we use in medicine that we think are interchangeable, but it's really important that you're clear in your diagnosis and that you're using the appropriate language. I also find it really helpful to have some support and patient and family education materials present during that visit, right? So whether that's from the Alzheimer's Association, they have great handouts for several different types of dementia, or the 36-hour day, whatever it is that you have available to you that you can share with patients and families. And then one of the things that I think we do a lot in medicine that's critical in these visits is reading the faces of the folks you're talking to, right? This is, again, a life-changing diagnosis. There are some folks who are going to have a lot of questions and want a lot of information up front. There are also patients who may be really upset or shut down or feel withdrawn, and it's really important to get a sense of where the patient and family is and what they need in that moment.
And then Melissa notes in the chat box that she's gone to her patients' appointments to help them or interpret and inlay friendly, patient-friendly language. And it's super helpful for those patients or family who have been labeled as difficult.
Yes.
And yes, and I assume, Melissa, that you're a care coordinator? I think that's an assumption on my part. Yes. Yeah, care coordination is definitely important for all of these patients because, like you said, Dr. Brock, this is a life-changing diagnosis, and it's not only life-changing for the patient, but also the family.
Mhm. And for those of you who are providers on the call, I can't underestimate the value of care coordination and talking to specialists, right? I think the residents that I work with here at Riverstone are probably sick of hearing this from me, but if they come to me with any questions about how a specialist is managing care or medication management, my answer is almost always to pick up the phone and call them, in part because that's how we learn their approach and why they maybe made a certain decision, but we also have a ton of information about our patients, right? For those of us who are primary care providers on the call. One of the beauties of family medicine on my end is that when I'm diagnosing dementia in an elder, I often take care of their children and their grandchildren and have a better sense of that dynamic, whether it's complex or supportive. I think that elders with cognitive impairment and dementia are some of the most vulnerable in what is sometimes a very treacherous healthcare system. And so all of us on their care team have the ability to advocate and make the medical system safer. And if that takes a phone call, I don't hesitate to pick up the phone and help to coordinate that care. I'm so glad to hear that you guys are doing that already.
Does anybody else have any comments about what's gone particularly well for you in working with patients and families?
One question I might ask Dr. Brock is, with integrating family and caregivers in general, is it more often than not, or how often do you see, are you in the situation where the family member or caregiver is sort of like teetering on burnout or already burned out? And so then how does it adjust your approach? You know, are you more aggressively trying to bring in outside help, or are there ways you help them set some healthier boundaries, you know, and do some self-care?
Yeah, absolutely. I actually have a patient coming into clinic this afternoon, and that's the entire reason for the appointment. We're getting signals from his wife that she is completely burned out and exhausted. And he is quite resistant to additional in-home support or a higher level of care. So we see this a lot. Again, a lot of it, if the caregiver also happens to be a patient, that's helpful in that sometimes I can have a separate appointment with them to get that information, though we don't always have that luxury. I think it's really important to acknowledge and talk about caregiver burnout in the presence of the patient if they're able to understand, right? And so a lot of that comes down to kind of your clinical gut and whether that conversation needs to happen with the patient present. Sometimes that can, depending on the type of impairment that they have, can increase agitation and not be very productive. But I generally will look at the patient and ask them how they feel like their caregiver is doing, right? To get a sense of how they feel. I find that no elder wants to be a burden, right? There are also elders who very much want to maintain their independence and see outside services coming in as losing independence, right? And so it's a balance, and trying to get a sense of where that patient stands on that spectrum can be really helpful. I've generally had it be pretty well received and kind of open the doors to outside services when I have that conversation somewhat frankly with both the caregiver and the patient present. And I will often approach it again from the angle of independence, right? If I'm sitting with a patient and their goal is to stay in their home for as long as possible, right? Often the way that we do that is to open the door to more outside services, right? Bring in home health or a personal care attendant, have someone help with groceries, so that the caregiver is less burned out.
I also did put in chat just a question, if you have done group visits for patients experiencing dementia, or I was just recently on something else, another echo dementia, and they were talking about the value of group visits and the fact that the support from other patients and other caregivers are sometimes taken, like you've walked in my shoes. You're not the doctor with the official title, but it's somebody else that's going through the same things that you are, and how helpful sometimes those group visits really can be.
We have not done group visits at Riverstone. I would be eager to hear if someone else has had success with that. Also, COVID has thrown a wrench in pretty
Right,
much all
right.
group visits, but even Zoom group visits can be
Yeah, this group is from Swedish, and they do virtual group visits. So I'd be happy to connect you with that physician.
Swedish in Seattle.
Yeah, Nancy Eisenberger.
Oh, Nancy's, yeah.
Eisenberg, yeah.
So, yeah, Nancy was one of the speakers a couple weeks ago. And University of Washington, who the Alzheimer's Research Center there that she also is affiliated with, they also do group visits. We did group visits, so the couple of years I was there, very successful, very well attended, seemed to be really popular. And so we continue to do that. And there's a little bit of a curriculum. I mean, we had like a whole ADAPT program that was sort of based on some larger studies. And so there was some cognitive training built in. I mean, it was kind of a whole series, just like what we're doing here in a group setting. So, I mean, if that was a positive, if there's, a population to support it, I think that's very helpful. I mean, I think a lot of them are offered on Zoom. Now, I know Alzheimer's Association has some Zoom classes as well.
And then we have a question from Simi. Do you know of any good alternative funding sources for patients who don't qualify for Medicaid but also can't afford to hire in-home assistance?
I am blessed to have an outstanding care management team at Riverstone. And so my first thought is I would go to those individuals and ask that question. We do run into the issue of funding quite a bit. Obviously, if they don't have Medicaid and they have Medicare, if they qualify for skilled in-home services, that's great, either through a qualifying inpatient stay, and that's not a long-term solution. We do have some local agencies here in Billings that operate on a sliding fee scale, which is more accessible to our patients than others, but we run into funding barriers as well.
Mm-hmm. And 211 is always a great resource for everybody to just Google 211 Montana or Wyoming, whatever state you're in, and look and see what's available in your area.
I also find that, and some of the care managers on the call probably know way more about this than I do. This has been part of my learning here, but there are a fair number of patients who are quite close to qualifying for Medicaid, right? And so with their spend down, may actually open up a number of services. And so getting a better sense kind of financially of how close they are can be helpful in terms of working with the care manager to see if they may qualify with the spend down.
Okay. Any other questions or comments from folks? Melissa says, I think it's important to ask questions to find out what support family members want. Some of the interventions we assume will work can actually be an annoyance as professionals. Sometimes we also assume there are services available when they're actually quite difficult to obtain.
Mm-hmm. Absolutely.
Yep.
Agree.
Yes, indeed. And I also know that, just given the stressors of the healthcare system right now, even those in-home support services have been hit hard with COVID and staffing challenges. So this is indeed a unique time in our history.
Often I think that what we're juggling is the line between, because often we're seeing patients or families present to us in a bit of a crisis, or when a point has been reached where there's some urgency, and so there it can often feel like our hand is being forced to recommend a facility, whether that's skilled nursing or assisted living or something, and most often, just statistically, that's not what the patient necessarily wants. The vast majority of people want to stay home and maintain as much autonomy as possible. So as kind of staff and providers, it's really hard to walk that line of trying to integrate their caregivers and families as much as possible to help them stay home, but not lead to burnout. Bring in community resources, which are often hard to find. Often you have to piece them together because someone's coming to you and you're saying, whoa, you kind of reached a point where you already need a ton of help, but their insurance, oh, well, for the first step, we'll approve 2 hours a week. And you're like, no, I'm telling you, I need more. But so often there's that mismatch. And so then you're piecing things together, looking for the volunteer services, the visiting angels. Sometimes our patients are lucky. I've been in Montana, it's more often than not than other states where you're lucky your patient will have like VA access. This is one of those places the VA can shine and help out because they also have private insurance, Medicare. So piecing all that together is kind of, I think, the art form that you have to master when it comes to dementia.
Yeah, I think one of the other challenges in Montana, especially in the rural areas, there's often not even home health services that are
Right.
being offered. And so it really is a network of some folks that can be hired, piecing together the volunteer schedule, including your local church or community groups that person has been active with. Sometimes you have to be quite creative.
Absolutely agree.
And I do know too, just from when my mother was experiencing dementia, the nursing homes often have like day programs, so it gives that caregiver a break, and then kind of gets them used to a little bit of more assistance as well.
Mm-hmm.
So, any other group comments, experiences you'd like to share? Okay, well, we can wrap up a little bit early. I'm sure we all could use a little extra time in our schedule. Yep, thank you, Maynette, for the evaluation reminder. We do look at those, so feel free to comment, and we will be here in 2 weeks. Thank you much.
Thanks, everyone.
Bye.